Hello again, everyone, and welcome back to the second part in a series that I've entitled The Why of Musculoskeletal Ultrasound Imaging in Physical Therapy. My name is Greg Fritz, and I'm a clinician in Washington State. I'm also very grateful to Clarius Mobile Health to allow me this platform to present how I find value in musculoskeletal ultrasound imaging in my practice. I'm offering 8 different diagnostic categories and how I believe musculoskeletal ultrasound imaging does a good job in answering questions in each of them. In the previous video, I covered areas of support structure imaging and how ultrasound allows us to assess not only the location of the injury and collagen fibers, but also where it is in the continuum of healing. Today we're going to be covering bony integrity and how ultrasound imaging can assess the structures of the skeletal system, and answering questions like, is there a lesion or a defect in the bone? Is that lesion a displaced lesion, like a fracture displacement? Is it an avulsed phenomenon, like a traction issue? Is it a compression fracture? Where is that bony tissue in the process of its own healing? Is it showing quality healing? Or is there, because of irritation, a non-union developing? There is an echo signature specifically for that. And as a physical therapist, our primary question is, what is the function of my patient? Can they return to work? Are they safe to do ADLs at home? And can they return to the ball field or to the court? Musculoskeletal ultrasound imaging provides evidence through assessing the callus formation and the remodeling of fracture sites to help us make those determinations successfully. And to demonstrate the utility of musculoskeletal imaging, I'm going to rapidly go through 6 mini case studies that I'd like to use to amplify the value of musculoskeletal ultrasound in the assessment of bony pathology. And we're going to begin with a very basic view of a fracture. This is a 55-year-old large-framed gentleman who presented to my office with a pain that he said occurred when he was being manipulated in his middle back just 2 days before. He went in to get an adjustment and felt a snap that created pain that he likened to symptoms he felt when he was in high school playing football. In this call-out, you will see rib number 4 is going to show up, and along with it, there is a blue line that's going to represent the long axis view that we're going to take a look at in this slide here. If you notice and follow my pointer, the hyperechoic, or the bright line associated with the cortex of the rib, is interrupted, and so a line break in the periosteum is one of the first clues that there is a discontinuum or a fracture in bone. The second area is going to be that there's a dark dome that will form as a metabolic weepage or some effusion, usually right over that fracture area. You will see now as we begin to move this image that there are areas that you can see fascia being stretched and darkness or fluid occurring. And that effusive dome is very common and helps to identify a fracture if it is not clearly displaced. You'll notice now this orange line is going to be placed in short axis over the 4th rib, and that also is going to be shown in this call-out here on the right. Pulling up the image, you will see the periosteal echo, the hyperechoic line that you're going to be expecting to see in a crescent shape when you take a look at a rib. And as I move that rib from front to back, you're going to see uniquely, starting on that side, the actual structure change. And you're going to see that as I'm moving it, I'm sweeping it along the orientation of the rib, and down here you can see lung material on either side. But as we're moving that along the rib, you can see that that discontinuum moves from one side of the image to the other, which means that the fracture itself was not perfectly in the short axis plane. This next one is a fun one. This was a 15-year-old young man who presented with pain in the outside of his left hand. He was playing football and caught his little finger in the jersey of an opponent. His father was a patient of mine and said that his son had been on the sidelines with this pain for about 2 or 3 days, and he wanted to see whether or not he should be taking him in for further studies. So I invited him to come over to my house. I pulled out my Clarius L15 scanner and my handy-dandy iPad Pro and did a quick view of the finger. And so this blue line right here is going to be demonstrating the long axis view, and under that long axis view, this is what you see. This is a view of the proximal phalanx bone. And as we begin to sweep back and forth over that bone, I want you to notice that the white line is not continuous with the other white line. In fact, it looks as though a component of that bone is being shoved up into this other white line, so that the plane of this bone breaks the plane of the other bone, and there is quite a bit of fluid around that area of the bone. And then as we take a look at the short axis, represented by the orange line in the picture, and a normal echo texture of round finger bone shows up like an arch or a bright white crescent. And as you watch that I scan proximal and distal on this bone, there's going to be unique prominent points, almost like a shard that sticks up from that bony surface. And so after seeing both the long axis and short axis deviation of the periosteal echoes, I sent these parents with their son to get x-rays. And this is the x-ray. You can see that the distal component of the proximal phalanx had actually slid proximal, making this distance shorter. These type of spiral fractures really require internal fixation. And so within 2 days, they had this young man in, and this finger was pinned. So in the past 2 studies, you've been able to identify the bony fracture as quite evident discontinuum in that bright white line of the bony periosteum. And you've also been able to see the darkness of the fluid associated with the metabolic weepage from that bony lesion. This third case, however, is going to be a little bit more difficult. This is a 45-year-old female mega marathon runner who in the past week, prior to me seeing her, had run one race that was 250 miles long. She said that toward the end of the race, she began to develop discomfort and indicated with her finger that that discomfort was located in the lateral aspect of the outside of the calcaneus. So knowing how sensitive ultrasound is to identify stress fractures, and realizing that she had already had plain x-rays that did not show a fracture, I asked myself whether or not I would be able to see anything that would indicate pathology at all. So I placed the probe, as you're going to see here, on top the calcaneus on the outside and obtained this image. And appreciate with me the white line of the bone, and look close, you'll be able to see a dark area that makes a very small dome, and that dome correlates not only to a change in the bony matrix, but it also is directly located as to the point of maximal pain. So when I pushed the probe up and down on that spot, I was very confident that underneath there would be a stress fracture. And sure enough, 10 days afterwards, we ordered another x-ray, and it came back with the identifying signs of callus formation that was dense enough to be evident on plain x-rays. This gentleman presented with right-sided knee pain and claimed that he was getting out of his car at work when he slipped with his left leg and landed heavily on his right leg, bearing his body weight, and felt a snap on the outside of the knee that developed into some swelling and generalized discomfort. He was then seen at the facility with the safety officer and decided to bring him to my clinic to evaluate whether there was any structural damage that needed to go to advanced imaging. You'll see the femur here on the left, the tibia on the right, and the patella in the middle. And you'll recall that you can see the suprapatellar pouch through a window just above the knee cap, where you'll find the quad tendon and the fibers that go to the quadricep muscles. If you do look down over that area, and you can see here the actual suprapatellar pouch that we saw on the last presentation, and you'll also see that the quad tendon is at the top of the kneecap, and you can see the fibers that represent the three components of the quadricep muscles. I want you to keep this in mind, particularly the echo texture of the kneecap, and remember the thickness of the quadricep tendon. Because when we went to the involved side, I want you to see that the kneecap echo texture, that arc of hyperechoic brightness, stopped, and what we had was the hyperechoic or bright echo texture down below a very thin region of the quad tendon. Pieces of the bony structure of the kneecap retracted and created an avulsion lesion where the force from the fibers that went into the patella literally pulled part of the patella apart. And part of the reason that we know this to be dense structure is that we can see darkness, or what we refer to as posterior echoic shadowing, where we don't see anything below those bright lines. This did require an MRI, and they identified that there was a partial thickness tear of the quad tendon, avulsing the vastus lateralis. Oh, this is a good one. If this case study does not get you convinced that ultrasound imaging for bone pathology isn't valuable, I don't know what will. This was a retired golfer who presented to my clinic, claiming of some sharp pain he was experiencing in the outside of his ankle. He said that it had been worsening, but that it was perfectly fine in most of the positions, except for when his foot came up, just at a certain degree. He could move beyond the pain, and he could go well into body weight loading, even could run without discomfort, except in certain spots. And after 18 holes of golf, that was different. Things were just generally achy, and some swelling actually occurred. He asked me, hey, do you think you could look inside and see what possibly is going on? Because it was just plain odd to him. So let me draw your attention to the talocrural region, where the distal tibia, the distal fibula, and the talus have their articulation, or their joint. You will see that there is articular cartilage all the way down on the talus, and that's particularly important because when we put the probe right where this blue line is, you will expect to see some dark areas representing articular armor over the top of the talus. And just like we were saying, this region right here is that articular armor that is right over the top of the talus here. And you'll notice off to the lateral component of his ankle, there is a, let's say, cloudiness in that echo. Now, when I hit play on this video, you will see that there are parts of the top of that dome that have complete black armor or cartilage all the way across. But I want you to watch this white line, this area that we know to be the cortex or the bony echo. So here we go. We're going to hit start. You're going to see that that line does, in fact, continue as we go to the back. But notice what happens. There is an erosion. There's almost like a sinkhole in the top of the talus. What you're looking at here, right in this zone here, is an osteochondral defect. These are nearly impossible to see on X-ray. They require MRIs to identify, but in the research I've seen, the actual field of view we can have by having the patient dorsiflex and plantarflex covers about 90% of the common areas that OCDs will occur in ankles. So we come to the final category of bone pathology that I want to demonstrate can be well assessed in your practice with imaging ultrasound. This is a lady who came in to address issues of ongoing sharp pain in her toe following a bunionectomy. And she was concerned that there was too much pain compared to what the doctor had discussed with her she should expect. And the doctor simply filled out a prescription for physical therapy stating we need to get this toe moving. He had assured her that he felt it was progressing appropriately. Here are some images that I have put together of x-rays showing the staple that was used to hold the proximal phalanx together and some screws that were used to address the distal metatarsal. This is going to be our first image that's going to show the joint between the distal metatarsal and the proximal phalanx of the great toe. I'm going to demonstrate to you the actual scan, and I want you to watch and see that we are able to easily identify the echo texture of metal. But when you do see hardware in the field of ultrasound, it has what's called the ring down. It is almost like a waterfall effect of sound, and it has to do with the physics of the way echoes return back to the probe. But as I play this, I want you to notice that we can make judgments based on what the actual structures are simply by looking at that echo texture. So you can see here the white line that showed up. You can see the bone, and you can also see all of the osteophytes that are forming around there. There again is the staple. You can see fluid all around here associated with the staple and the hardware. And there's evidence, as you take a look at this structure, that there's ongoing callus formation. To document whether or not there is still a process of hyperemia or healing, we can put on the power Doppler, and you'll be able to see that in this region there's actually inflammatory reactivity. Now, we're too far in that bony reformation and remodeling to have this level of inflammation if we were not having ongoing acute repair. So, this particular study, I was able to identify that there was ongoing effusion, identify that we were still having the support metabolics of an acute inflammatory phase, and this patient needed to have prolonged time in a immobility boot, not aggressively pressing for range of motion. And so let's get to the questions that I know ultrasound can answer in your practice for you as it relates to bone. Can you see fractures? Yes, of course you can. You saw them at the very beginning case studies. Very obvious clefts in that white line that makes up the bony structure. Can you visualize the process of healing in bone? Yes, you can. You can see the tissue changes. You can see the changes in the densities that are associated with the callus formations around the bone. And as such, you can see the metabolics with the varying processes of healing. There's an entire video that's coming up in this series that will be addressing the inflammatory phases in soft tissue and in bone, and that will be helpful as we take a look at these answers. Any chance to be able to see stress fractures or overuse fractures? Well, in fact, we can see stress fractures faster than you can see them on plain x-rays. That was documented in that mega marathon runner. We were able to document the existence of a stress fracture 10 days before we were able to see it on x-ray. Isn't it cool to be able to say, yes, you do have a stress fracture? And it's not just in the calcaneus. We can see stress fractures in the base of the fifth metatarsal and in many of these common locations to identify you better slow down and take it easy or this is going to develop into something even worse. Can ultrasound be used to image around hardware? It not only can be used, but it is unusually good at imaging around metal and surgical hardware. If you've ever had a chance to see what metal looks like on a CT scan or an MRI, there are wonky, bright spots all over the place that totally throw off your ability to identify the surrounding hardware. And in plain X-rays, you have to vary the exposure in order to even try to see bony structures. It's simply not nearly as good as ultrasound. So I want to go over with you what we've learned in this particular video, that ultrasound is able to clearly identify bone fractures, that there are echo signatures that help us to identify even how old that fracture is. We can take a look at the formation of the brightening tissue of callus. We can take a look at the darkness associated with fluid weepage, and we can identify the healing phases that are developing within that bone repair. We can also see tough-to-find fractures, lesions that are actually stress fractures that take up to a week or two to be well identified on plain X-rays. We can see avulsion fractures, where we can identify pieces of material from the bone that show up like gravel or debris in soft tissue, and that posterior acoustic shadowing identifies them as calcific masses. We're able to identify bony erosion with osteochondral defects. We can see the signatures of cartilage and watch how degeneration is starting to occur in the cartilage. Finally, we're able to well identify structures directly adjacent to metal hardware or plastic hardware. Ultrasound imaging in the practice of physical therapy, if all we had to identify was bone, would still be a valuable reason to utilize this tool. The next time we get together, I'd like to talk about the healing phases in varying tissue. So join me next time on my next video, in video number 3 in this Why series, as it relates to identifying tissue healing phases.